of really catch folks up as they join. So welcome to our second session of the SMBP Regional Affinity Group. Hopefully you had some good takeaways from the previous session and you were able to come with some questions and potential ideas for how you want to move forward with your implementation of your program. So in the spirit of innovation, I just want to ask the audience for our icebreaker question today. What is something that you've done either professionally or personally that has challenged you? Just kind of something to think about. I think challenges keep us young and keep life a little bit exciting. So what is something that you've done that challenged you? Erin, what have you done recently?
Oh man, I was just thinking about what it would be. I was like, my first instinct was children. They always challenge me, but in good ways and bad ways.
I love it. Yeah, that's certain children are certainly dynamic. That is for sure. Chris, hello. Okay, Patty, what about you? What's something that you've done recently that's challenged you?
Well, I hate to say that I had to learn something new. I don't have a clinical background and I'm doing a presentation for the American Heart Association and I had to take on a topic I'm not comfortable with. So that's my new challenge.
Okay. Dr. Humphrey, what about you? What's a challenge that you've had recently?
Not terribly recently, but we've recently purchased a house on the Big Island, and my daughter took me stand-up paddleboarding. For seniors, that's a little more challenging than if I was 20 or 30 years younger.
I love it. Yeah, I've never paddleboarded in the ocean or moving water besides a lake for that matter. So that is certainly a core exercise. That is for sure. Well, for me, actually, it was last weekend. I got a little harebrained idea to get my Swiftwater Rescue Technician certification. So working on river rescues here in Montana. So my husband and I tackled that challenge, which was not only emotionally challenging, but incredibly physically and mentally challenging. But I came out of it feeling a bit more confident that I could at least address a situation should it arise when we are out recreating. Hope, you are on video. I see you. How are you? What is something that you've done that's challenged you?
Well, since the pandemic, I signed up to be an integrative health coach. So I'm taking a health coaching class, and that's been challenging and fun and scary.
Well, that is exciting. What certification are you going for the health coaching?
It's an integrative nutrition.
Okay, very cool. Sounds like that interfaces potentially with some lifestyle change that may come from SMBP, right?
Yeah, right. Yep, absolutely. Wellness, absolutely.
Great, great. Well, thank you everyone for sharing that. I think some of us are in a new world with the implementation of SMBP, and this may be something that challenges us a bit professionally as we move through the different courses that we are working on today. So just quick housekeeping. We're going to kind of reiterate these every time. So you can either tone out, refresh your coffee, or take a bite of your sandwich before we get into the meat of the discussion. But all lines are live. So we just ask that when you're not speaking, you go ahead and mute your line. You will, hopefully become prepared to share, whether that be, successes or challenges. We have some great subject matter experts at our disposal, but as we work through this process, ultimately you all are becoming the experts. So we really want to hear, what you are seeing and learning in the field. Feel free to put your questions in chat or come off of mute. I saw that Penny doesn't have a microphone. Totally fine. Our chat feed will be monitored. Another great way to collaborate. My name is Kristen Schuster. I'm with Mountain Pacific Quality Health. I guess I'm kind of your moderator throughout all of these sessions, so you'll get pretty familiar with my voice. I am thrilled to have Erin Ackelstad from Mountain Pacific Quality Health as well. She is up in Alaska. I am technically down in Montana, but we have folks on the line from Wyoming, Hawaii, Alaska, and Montana. So a very nice, diverse group of states on the line. So today we like to establish the ground rules, our ABCs. So assuming our positive intent, we ask that you be here in the now, come prepared to share, decrease distractions and respect time, and then my personal favorite of everyone teaches and everyone learns. The SMBP Affinity Group is in partnership with a variety of regional partners, not only Mountain Pacific, but all the way through to the National American Heart Association, the Alaska Primary Care Association, Montana Primary Care, the Departments of Health from each of the 4 states represented on the line. So this is meant to collaborate with lots of different partners that are working on hypertension, cardiovascular disease, diabetes, and really capitalize on all of the different experts that we have at our disposals in our respective states. So for today, we are going to look at kind of our step 2 of SMBP implementation. So we are going to review the call to action items that we established a couple of weeks ago. It's crazy how quickly time flies. And then we're going to get into some patient identification and education. I'm thrilled to have a provider from Hawaii that's going to be one of our guest speakers in the series, share some expertise around what that looks like in their organization. Then we're going to touch briefly on SMBP billing. Then we're going to get into our discussion portion and Q&A, and then close out with our call to action and homework assignments. So before we get into today's presentation, want to see how things went over the last couple of weeks. So we kind of established we wanted to see which model you were going to look at, whether it was going to be patient purchased, clinic purchased, or perhaps a hybrid. So what implementation model did you decide to explore in the last couple of weeks? You can either feel free to come off of mute or go ahead and chat in your response, but want to see which way you're leaning towards since we last met. All right, Jamie chatted in, likely going to do the hybrid model. That's great. So that's going to be a combination of patient purchased cuffs and clinic purchased cuffs. All right, Tanisha says a hybrid model as well. Same with Cynthia. Oh, hey, Cynthia, glad you were able to join. And if you didn't make a decision, that's fine. Nothing wrong with that at all. So if you can say, you know, you're unsure, that's totally fine. Chris, so we are looking at either the clinic purchasing cuffs, the patient purchasing their own cuffs, or kind of a combination of the two. I think you all are pretty much going with the clinic provided cuffs, if I'm not mistaken. Perfect, great. Chris has kind of a combination of cuffs that were purchased by the clinic, a grant from the American Heart Association, as well as some cuffs that were provided through cardiovascular funding from the CDC. So puzzle piecing those together is a great way to you know, get a good quantity of cuffs within your practice without necessarily having to foot the bill for every single cuff, or putting that responsibility fully on the patient. Okay, so it looks like I haven't heard from Ashley or Hope. You guys want to chat in or come off mute? Oh, Penny says we have cuffs from Mountain Pacific. Yeah, that's great. Penny, are you up in Alaska or are you to my south in Wyoming? Wyoming. Cool.
Yep.
Yeah. We have success. We have all of our states represented today. I love that. Great. So this can change. This can, you know, be something that's set in stone from day one. This can, fluctuate over time depending, maybe you have a bunch of patients that decide they want to purchase them. Maybe a commercial or state payer partner decides that they would like to give the patients cuffs. No matter what, this is just kind of that initial step that you want to take as you kind of explore what it's going to look like, if a patient is bringing in their own, if you need to check them in and check them out, what kind of administrative work that needs to be kind of associated with these respective models. Any early successes or challenges that you kind of identified based on our homework from the last session. So that was looking at, which model you're going to choose, how you're going to educate your care team members, and then establishing a physician champion for your SMBP project. Any early successes or challenges?
So someone has
Early success. Oh.
Yep. Sorry, Kristen, do you want me to read them off?
Yeah, that would be great. Thank you.
Yeah, so Jamie says early successes they have an MD who agreed to lead, and we got that same feedback from one of our Alaska clinics that wasn't able to join today. So a couple of provider champions, that's great. And then Christine says patient commitment, that's huge. So sounds like people are moving forward. And Penny is saying challenge with patient time and no real provider lead. So that's one of the challenges that was presented. And Tanisha, success, we received all 20 of our new blood pressure cuffs. So the state of Alaska provided cuffs up in Alaska. So congratulations, Tanisha, that's great. And then Christine has an early success. Patients who have enrolled were able to connect their BP machines to our smart devices. Oldest was 83 years old. Nice. That is a huge success. Congratulations. And then Jamie has a challenge going through some staff and clinic changes, so unsure exactly how soon we can start up the program. And Christine has a challenge with patient commitment. And then Jerwin added identified patient to be included in the program. So some early successes. It looks like everyone's committed to kind of putting it in place and doing the early steps. Kristen.
Hey, that's why we're here, right? So I'm glad. So good that this is a pertinent topic, and there was some good traction that was made. I'm really excited that our presenter today is going to talk about the perspective from a provider as well as a seasoned veteran in the SMBP world that hopefully can help address some of the questions, either identifying a physician champion or patient engagement strategies. So hopefully that is going to be a good topic for today. So with that, I'm going to pass it over to Kendall with the Hawaii Department of Health that is going to introduce our presenter today. Kendall?
Yes, we're very happy to introduce our guest speaker, Dr. Joel Humphrey. He's an internal medicine physician and former medical director of the Lanai Community Health Center, FQHC. So he'll share about his experiences and lessons learned over the years with SMBP implementation. So hand it over to Dr. Humphrey.
Thank you very much, Kendall. Yeah, it's certainly an honor and a pleasure to be here to share our experiences at the Lanai Community Health Center. Next slide. The Lanai Community Health Center is on the island of Lanai. For those of you who are not real familiar with Hawaii, Lanai is one of the islands, and our health center sees approximately 2,000 unduplicated patients in a given year. We started our SMBP program in 2014, and in 2017, we moved our patients to Bluetooth-enabled remote monitoring for their SMBP. Next slide. Yeah, this is a quote from last week's or the last first webinar. And the evidence shows that a well-funded, highly structured, research-driven SMBP program improves hypertension control over 18 months. That's a scientific published data. The evidence also shows that using SMBP to establish or diagnose a population with hypertension defines a very different population than is currently diagnosed in the clinical setting. Next slide. And this is probably the most important slide. I mean, office blood pressure is steeped in tradition and is the financial bread and butter of primary care, accounting for about 30% of the chronic disease visits. Tradition is a major obstacle in transforming our delivery system. SMBP does not comfortably fit into a routine office practice. Our first lesson learned when we implemented SMBP in 2014 was that we had to change the way we delivered care. Next slide. I would like to give you our perspective of some essential components of our program development. Currently, the American Heart Association and Million Hearts guidelines recommended SMBP for all patients with hypertension. Plan to have 100 or 200 or more patients on your SMBP program. Think big. The initial steps in transforming the delivery system related to hypertension CVD managed. The initial steps are transforming the delivery system related to hypertension and CVD management. SMBP needs to validate the diagnosis of all patients who carry the diagnosis of hypertension and are in good control. We are treating patients who do not have hypertension. Expect to alter treatment and better define those patients with white coat hypertension, masked hypertension, and misdiagnosis. SMBP is the best practice, given the well-documented inaccuracies of office blood pressures in predicting cardiovascular disease outcomes. Both the leadership and the providers need to be committed to the SMBP program. SMBP is more about doing the right thing than aligning financial incentives to transform practice patterns. Successful programs have been able to reduce office visits for hypertension management by 23%. Pharmacy costs are likely to go up with better hypertension control and improved medication adherence. However, some patients see a reduction in medication and savings in reduced office visits. Buying cuffs in bulk leads to significant savings. HMSA, which is Blue Cross Blue Shield Hawaii, assisted LCAC in purchasing validated blood pressure cuffs at $39 a piece if we bought in bulk. Giving cuffs away may be less costly than establishing a large BP loaner program requiring signing in and retrieving blood pressure cuffs. It is best to have a single brand of cuff so the team is familiar with the training of patients on a single system. Many hypertensive patients have comorbidities. Team care needs to care for the patient and not just hypertension. There needs to be redefining roles, not only staff training, but high levels of care coordination. It is recommended to have an organizational level of hypertension treatment plan or protocols rather than leaving therapeutic decisions up to individual providers. Information technology is essential in the long run. Currently, few organizations have IT support to receive, review, and analyze patient data. We gather 3 readings a minute apart on morning and evening with a 7-day period, or get 70 or 42 readings rather than 1 or 2 readings in the office. Many patients gather additional readings. Some share cuffs with others, and there's obviously periodic technical failure. Reading over multiple days significantly improves the quality of the data correlated with cardiovascular risk. Computer software can clean up and analyze the data, greatly assisting decision support for patients and for the care team. Before the program starts, make friends with your CFO. I do not see how current reliance on fee-for-service models will support the IT and team-based care. As a safety net provider, we initiated or invested significant more human resources to obtain desirable patient outcomes than we can cover with our current existing payment system. New payment models are in the pipeline, but they may not be implemented for the current initiating programs. FQHCs have financial advantages over other providers caring for Medicare and Medicaid patients. But we've had to cut back on certain aspects of our program when grant funding ran out. Next slide. Where's the endorsement from the two national primary care organizations? My Google search for SMBP preparing for this presentation with the Annals of Internal Medicine and the American Family Physician essentially found no mention of SMBP. The Annals of Internal Medicine's article, should out-of-office monitoring be performed for detection of white coat hypertension, which was published in June of 2019, concluded maybe, but we do not have evidence of improvement past 12 months. A single end of year BP reading meeting the 140 threshold has not been shown to lower cardiovascular risk for a population. This is a HEDIS measurement from NCQA identifying the population at risk for CVD using ambulatory blood pressure monitoring or SMBP, and lowering the blood pressure effectively with effective management does lower CVD risk associated with management of other risk factors, LDL and smoking. That is the science. There's nothing magical about our blood pressure reading of 140. The cost of transformation. Change costs money. Pay for performance incentivizes change, but only rewards after successful change. That's value-based payment. With SMBP, we improve patient outcomes, but those that initiate transformation of the delivery system are not guaranteed of success. There are successful programs. We need to work together to assure improved patient outcomes and have adequate funding to cover the cost of change of the delivery system. We need to keep in mind that only a high structured program with health information technology support for monitoring and measuring outcomes has been shown to be effective. How should we implement SMBP in the middle of a COVID-19 pandemic? Change is highly correlated with provider burnout if imposed rather than desired by the providers. Medication management by pharmacists is often not coordinated with the providers. Where does telehealth now fit into the delivery system? And will the payments continue or change? SMBP is best implemented with HIT support. Most successful integrated SMBP programs are with Epic in organizations with large IT support. Current remote monitoring applications are not coupled with the appropriate analytics to support SMBP and are not SMBP specific. Health IT is a work in progress. Current programs need to plan for future IT support. Next slide. Yeah, Thomas Frieden, previous director of the CDC, wrote that blood pressure control can save more lives than any other clinical intervention. SMBP implemented correctly best diagnoses a population requiring treatment, improves patient engagement and self-management, and provides a tool for shared decision-making between patient and the care team. I want to recognize the Lynette Community Health Center's healthcare team for their tremendous contributions in our building our SMBP model of care. And with that, I'll turn it back to the folks.
All right, great. Thank you so much. There's a lot of great information in there, and I would like to, see if anybody in the audience has questions about, the strategies that were used, or, just ideas and best practices. 2014 to now is quite a long time to get some lessons learned. So I encourage you to take the opportunity to ask Dr. Humphrey any questions that may address some of the needs that you're facing. All right, Chris says, thank you. This is great as we begin our SMBP program. Definitely, it's always good to have some trailblazers to know that there's a great potential for success.
One of the things that I thought you said that was helpful for me, Dr. Humphreys, as I'm helping people, is about that it might save you more money by handing out cuffs than doing a loaner program. So that was quite interesting. And then the second thing is getting all the same models of cuffs. So you can cut back on the training that's required there. So I think both of those were really good best practices to share with the team. Thanks so much.
Yeah, I would comment. Yeah, part of it was certainly with the remote monitoring, which is essential with all the successful programs. If you're going to have people bring in the cuff and then upload, or patients, or as the AMA recommends, have a patient keep an individual log of all their blood pressure cuffs and bring in a sheet of paper. It's not scalable to 200 patients.
Yeah,
so you have to have the remote monitoring, and for the remote monitoring, each vendor has a different different transmission. So you're going to have to build interfaces for all the different cuffs for all the different patients. So when we were doing it, knowing that we were going to do remote monitoring, to make the IT part work, we had to have a single set of cuffs. Plus it's really easy for our team to know that cuff well and know how to set up the Bluetooth and know how to train the patients. Each vendor has a different mechanism. So if a patient's having trouble, you're going to have to go back to trying to figure out what's wrong with that cuff.
Right. We have a question from Jamie as well. She's asking, can you clarify, did you say that you are asking patients to do three readings in one sitting times 7 days per week?
Yeah, that's the AMA recommends 2 readings in one sitting, a minute apart. So you put the blood pressure cuff on, get it, wait a minute, get another one, or wait at least a minute and get another one. The Million Hearts is either 2 or 3 readings. It's funny with white coat hypertension, or just hypertension in general. I mean, the numbers change dramatically from 1 minute to the next. So, and what really counts for getting good data regarding what patient's hypertension is getting multiple readings. You cannot rely on a single reading, either from home or from the office. And the more readings you get over the longer period of time, the more it will correlate with ambulatory blood pressure monitoring. And the first reading, it actually works with me. Literally every time I put the cuff on and get my first reading, it's always higher than the next 2. And that was pointed out to us, that just putting the blood pressure cuff on in certain individuals elevates the blood pressure. And I like to see that, because if I see a patient whose pattern typically has a high blood pressure on that first reading, then I might not change therapy as rapidly, knowing that his average blood pressure, the morning and evening blood pressure does correlate with ambulatory blood pressure monitoring, the 24-hour monitoring. And so it's a good surrogate, and most patients don't want to wear a blood pressure cuff for 24 hours, particularly at night when it wakes them up every half hour. So it's an acceptable alternative for getting ambulatory blood pressure monitoring. But the other data that recently came out showed that 7 days average works better than just a single day's average, that your blood pressure over a period of time is a better predictor of cardiovascular outcomes than a single ambulatory blood pressure reading for just 24 hours, as correlated with stress on the heart. So there's pretty good evidence. We accept 3 days worth of readings because 7 days is not always what you can get from patients. And getting patient adherence is really critical to making the system work. And that takes some explanation for the patients to understand exactly how to do it. Once they get the blood pressure cuff on, it's just as easy to get three readings as 2 readings. It only takes a minute longer. And I'm a diabetes expert. I'm so glad that blood pressure monitoring doesn't mean finger pokes, because getting patients to do home sugar reading is painful and cumbersome and probably takes longer than the SMBP.
We have another question from Jamie again. She's also asking, was there a set number of weeks your program was planned for?
No, we've, yeah, we built ours around the research from Dr. I'm blanking her name, but and it was published in JAMA. So she shared their protocol, but they were the ones that basically did the U.S. research on ambulatory or self-measured blood pressure, and as the basis of the AHA recommendations for SMBP for everyone. And so, yeah, so, you know, plan to switch to SMBP. I mean, the data is overwhelming that that's a better way of managing hypertension. And I'm obviously frustrated with the primary care organizations who, you know, have not picked up the recommendations from the American Heart Association, which is very heavily supported by the international literature. So yeah, plan to stay with SMBP if indeed you're going to lower cardiovascular risk. And I don't have time to go through that literature, but I certainly have accumulated a number of articles, and there's real good documentation in the AHA literature that has come out over the last 3 years.
Can I just ask for a clarifying question there, Dr. Humphrey? So I'm not sure what Jamie means by how long of a program, but my question to you is, how long do you ask a patient to take their blood pressure?
Yeah, there's three pieces there. One is diagnosis, and that, I mean, we had all of our patients, you know, go home with the blood pressure cuff, and we compared those to the readings in the office, and sometimes there was correlation, but yeah, everybody, and you have to validate the blood pressure cuff with the office blood pressure. Those are calibrated blood pressure cuffs and should be the standard to make sure the individual blood pressure cuff's doing what it's supposed to do. Because if you get a blood pressure, we have had, my estimate's 1 out of every 50 are sort of lemons. They don't work the way they were scheduled to work. So yeah, but to diagnose hypertension, well, you need a loaner program, because you don't know whether the patient has hypertension or not. You don't want them to buy a blood pressure cuff and then tell them they don't need to use it. So so we have a loaner program, which we use for patients who don't have hypertension, but where we want to, for one reason or another, monitor the blood pressure. Then the second is in changing management of hypertension, where somebody has hypertension and we're constantly changing their medication, trying to get them under control, or changing their diet and encouraging lifestyle. And in those situations, while you should get a repeat blood pressure reading when you think the medication's effective. So, and most of the medications are effective within 1 to 3 weeks. Hydrochlorothiazide takes longer than, say, an ACE inhibitor. So the patient should do their 7-day reading a week after they start an ACE inhibitor, or 3 weeks after they start a hydrochlorothiazide type medication. And then you have the maintenance folks, which is where the blood pressure is well controlled and the patients are well managing themselves. And as we do in the office, patients that have well-controlled hypertension often are scheduled back 3 to 6 months and often 6 months in. And with their home blood pressure monitoring, they actually don't have to send anything in for 6 months. And then they can basically just have a reminder and do a week's worth of data collection. I've encouraged patients to sort of send information in on a monthly basis just to keep the self-management and keep us in touch. So that's an individual provider decision. But I think from a management standpoint, hypertension doesn't change very rapidly in most individuals unless they have some type of secondary hypertension. So if they're under control now, they're probably going to be under control in 3 and 6 months on their current medication and management unless something changes. Does that answer? Hopefully that answers it.
Yeah, that was great. Thank you so much. Kristen, I'll turn it back to you.
Great. Well, thank you. And if any other questions kind of pop in, I think we have our guest for the remainder of the session. So feel free to chat in on any other questions. Sounds like there's a lot of kind of fluid ways that you can approach this. And it may not be a one size fits all for every provider team, for every patient. So having some flexibility built in and understanding that things, can evolve and change and fluctuate from patient to patient seems like a pretty good lesson learned from that. So thank you so much for your expertise. And, it sounds like you may have teed up yourself to present on a future session. So I'll throw that out there. Great. Well, Erin is going to go through some program aims. So I will pass it over to Erin. Take it away.
Yeah, thanks, Kristen. And again, thank you, Dr. Humphreys. Talk about a wealth of knowledge, and I'm sure we'll be hearing from you again with questions throughout the rest of the session. But what I'm going to talk about here for a minute is the program aims for patients and providers. So the aim of these programs for patients are to enhance self-participation, improve patient knowledge of their condition, and improve medication adherence. So SMBP has also been associated with patient empowerment, autonomy, self-efficacy, and lifestyle modifications as they're an active participant engaged as a participant of the program. Next slide. So the aim of this program for providers are to ensure the full care team understands the organizational goals for implementing SMBP, including all levels of staff in the discussion for improving the communication within the care team, and kind of reflecting back on what Dr. Humphrey says, talk with everyone from your CFO to your IT team. It's gonna include more than just the provider. So including that whole care team. Another goal is to increase revenue. Like Dr. Humphreys also said, it's, sometimes it's not about chasing the money, but doing the right thing. But we're going to be talking a little bit about some of the billing codes here in just a little bit. So increasing that revenue by adding this as a clinical service line, and to improve timely and accurate hypertension diagnosis to avoid possible over or under treatment of hypertension. Next slide. So now we're going to talk a little bit about patient identification. So how will your patients be identified to be a part of this program? So kind of like Kristen and Dr. Humphrey said, it might be a little bit more, it might be fluid. It might be, you might have different protocols and processes or procedures for different patients. So those patients with uncontrolled hypertension who are on medication, or newly diagnosed patients with hypertension. These are some of the patient populations that you could target. Also those ones with undiagnosed hypertension, so with that white coat syndrome, so they may have you might have a different approach with those patients. And also patients identified as high risk with comorbidities. You can also use your data to support your efforts in identifying those populations where SMBP might have the most impact. So you could start with a pilot group or with an existing patient cohort, maybe have another active chronic disease program running that could align with this program. And I'll just again refer back to Dr. Humphreys. He said, think big, but start small. So it might be a good idea to just start with very few patients, what might be manageable for your practice. And I know we have quite a few states, so your clinic size might be a little bit different. So everyone's program might have a little bit different look and kind of process for getting patients identified. So when looking at the data to help support identify those patients, some examples of identification methods using your EHR could be to look at your quality reports. So patients identified in the denominator, not the numerator, of CMS 165, controlling high blood pressure. Looking at patients with a diagnosis code for hypertension on EHR problem lists. Patients with current use who are currently using medications for blood pressure control, looking through the EHR or through medical chart review. You may have risk stratification algorithms in your EHR, and you may have the ability to consider using registries to identify, track, and manage patients identified for SMBP. So you're going to want to establish your clinic's patient selection criteria and the identification method for your SMBP program. Next slide. So now we'll get a little bit into the billing for SMBP services. And since we have 4 states represented here today, we'll just highlight the Medicare billing codes for today. Medicaid coverage for home blood pressure monitors and additional support varies by state, and for private insurance carriers and self-insured employers, the decision to cover home blood pressure monitors and additional support is made by each individual plan. Therefore, it's good to check with your own state's payers to determine coverage for your patients and your services. And at some post-event materials that we're working on will include some different payer information that covers SMBP services across our region. We're just not going to dig into those today. So since January 1st of 2020, physicians have been able to submit claims for SMBP services using 2 CPT codes. The 2 codes address both the initial and ongoing SMBP clinical services. So that first code covers SMBP device calibration and training on setup and use, and it can be used once per device. That second code is used when participants use the SMBP device to self-measure their blood pressure twice daily, so that two readings 1 minute apart, minimum of 12 readings over a 30-day period, and communicates those readings back to the practice either manually or electronically. Next slide. So we're going to get into our next discussion question, our next one. So what criteria do you anticipate you will use to identify patients for SMBP? And I'm actually going to call on Dr. Humphreys. Can you talk to any about how you identified patients and what criteria you used, or is it kind of like fluid, each patient might be a little bit different scenario?
Yeah, we've got a small enough practice that, and we had very good provider support and team support, that essentially we started offering, initially we selected just offering patients that had hypertension to get that small group. I think, as I mentioned before, we actually were selling the blood pressure cuffs for $35 each, and patients have the opportunity to buy them because it may reduce their need for medication and or office visits, because we were able to do remote monitoring. Often they could get results without having somebody come in for a blood pressure check. And the $35 in our community, was very affordable. And if patients wanted it and didn't have the money at the time, why, we'd give them the blood pressure cuff with a commitment to come back and pay for it later. So we didn't worry about anybody wanted a blood pressure cuff, got one. Our major battle, so we used, the criteria, answer your question, the criteria was somebody was treated for hypertension or somebody was identified as potentially having hypertension, and we wanted to do the diagnosis rather than bring him back for an office visit, while we would give them a loaner. We do have good information systems, and so we are able to quantitate all of our hypertensives, and We also prescribed the blood pressure cuff so we could identify everybody that had a blood pressure cuff.
That's great. Thank you, Dr. Humphries. So does anyone have kind of any questions on this topic of criteria or identifying patients, or have you thought about, has anyone actually identified patients yet for their program? And again, you can use the chat or you can come off mute and kind of let us know.
We did get Jerwin did chat in that they are planning to use quality measure CMS 165. So I'm guessing that whoever is not in the numerator for CMS 165 to initially target is a good starting point. I think a lot of people are is a good place to at least start. Anyone else?
Absolutely.
Erin, so I had identified a patient that we were potentially going to do this on, but she had gotten something from her insurance in the mail saying that they were doing 30-day blood pressure monitoring for free for her work through a company called Live On Go. And so her insurance policy didn't actually cover it, but she could do the 30-day monitoring, and they provide a cuff through this other company for free. Have you heard of that at all?
I have not. I don't know if anyone else has heard of this. I haven't heard of it in Alaska for sure. But I did take a note of that, Tanisha, for sure, that we can talk about later this week, and I'll make sure I look into that between now and Thursday.
Yeah, because I thought maybe we could do it through us instead so I could get the data easier. But when I looked up her policy, like her insurance wasn't going to cover it, only through this other company they'd contracted to do it. So I thought it was kind of weird.
Yeah, I was going to add about Medicaid here. When we initially started in 2014, we prior authorized blood pressure cuffs for our Medicaid population because we had established that it was medically necessary, and the Medicaid has to pay for things that are medically necessary. The prior authorizations were approved, but we were never able to get reimbursed for the blood pressure cuffs because we were getting the blood pressure cuffs from the pharmacy, and the blood pressure cuffs are labeled as medical devices under the medical coverage, so that the health plans have them under the DME supplier, and the pharmacy can't bill for DMEs. They only bill for drugs like glucose strips, but the blood pressure cuffs are not, and we still have not resolved that issue. That's why we give out our free blood pressure cuffs to the Medicaid patients. But yeah, then the other, I mean, I cringe at what you just told us about the health plans getting involved with some device company or a vendor that's going out and measuring blood pressure cuffs. One of my previous jobs was 22 years at HMSA, which is Blue Cross Blue Shield, as a part-time medical director. And I was glad to leave there because we implemented and tried to manage clinical care, and it's the last place in the world you want this to come from. I mean, I just explained to you how highly structured it has to be successful. And those programs that are not successful are used by the American College of Physicians and the family practice to validate the fact that you should not be using SMBP, because the programs where you just hand out blood pressure cuffs have been shown not to be effective. You have to have a highly structured program. And so you've got to build a program that's successful, and clearly the health plans can't do that. This is a waste of time and money that they're doing, and it certainly screws up your program because they have a different blood pressure cuff than you have, and they're going to get the data and maybe share it with you, but it's the wrong thing to do.
Well, and that's what I was just going to say, Dr. Humphries. It's very difficult then to get the data. Even on just normal referrals like colonoscopies and things like that, it's hard to get the data from the specialist. It's going to be twice as hard from a payer partner. But
yeah, and I would say the payers is definitely a barrier. Also, is because not many payers. I know in some of the states, I've mostly done most of my research in Alaska, but there's not a lot of payers supporting these services or reimbursing for them yet.
And then one other comment I have about the criteria is we're working with a handful of clinics here in Montana, and they've actually shifted their attention from the high risk. They've done a lot of work around their high risk patients and have challenges getting movement there. They're looking more at their low to moderate risks, and it opened up a whole new patient panel for them to focus on. So I just was going to throw that out as another possibility to think about.
That's great, Patty. You know how much I love moderate and rising risk patients and potential lifestyle interventions for them. So thank you for sharing that. We did have Jerwin chatted in that they're planning to use quality measure, the CMS 165 in their EHR system. Chris chatted in, we've identified through BP registry, EMR problem list, and provider identification, and CMS 165. So, you know, quite a few different methods of kind of data collection and looking at various areas. And then Jamie chatted in, for the pilot program, we have brainstormed a few ideas: patients with both diabetes and hypertension, okay, recently diagnosed with hypertension, and then recent ED hospitalizations related to uncontrolled blood pressure. So a wide variety of potential ways to look at how you're going to, you know, look at potential patients, you know, and when you're looking at something new, any kind of a program, you know, casting a wider net out into your patient population is definitely a good way to get some exposure and interface with patients that, you know, maybe, you know, you aren't doing chronic care management with or longitudinal care management. You interface with them very frequently, but you can start exploring some different methods for looking at, you know, kind of new patients where maybe we can look at more of a prevention type of care versus that long-term care management. So we are going to move on to our next discussion question. Take it away, Patty.
Sure. So discussion question number 2 is, how many patients do you plan to target to begin your program? So we were just curious about what your scale is. And one of the things that Dr. Humphreys did recommend is kind of starting small and not getting too overwhelmed. Has anyone thought about a target number of patients to start? So it looks like Christine is saying originally we want to target 15 patients. Anyone else have any idea, or Dr. Humphreys, anything to add to that? Any recommendations?
I'd reflect back to our PDSA cycles and the idea of starting very small with just a few patients, or if you're going to do a LUNA program or getting it started, well, you may want to go up to about 25. I think more than 25 would get a little bit confusing as you put things in place. It depends on, I mean, this absolutely takes a team-based care. So the providers are not involved in the structural aspect of data collection and education and things like that. That actually has to be for the rest of the team. So it depends on your human resources as far as how you're going to be going about setting these structures up, and then looking at refining it with PDSA cycles.
Great. And it looks like everyone's thinking about 10 to 15 or so. Great place to start. All right, Kristen, back to you.
That's great. Yeah. What is my favorite thing that I like to say for the clinics that I work with is baby steps to greatness. Absolutely. Don't do a full-fledged 100-patient panel. You might drive your care team manager a little crazy if you try to dive in that aggressively. So start small, explore these different areas for, you know, how you can refine the processes. Go ahead, Patty.
I just wanted to bring your attention to a chat that Cynthia just put in. You might want to look at that.
Oh, yeah. So Cynthia chatted, this is about Live On Go. Okay, it's connected to Teladoc Health. She said, I've heard something about this as well. Insurance companies are a new barrier to care and dictating options for the patient. do we need to consider having patients or staff check insurance coverage as we identify patients to participate? That is a really, really good question, and one that I think that each individual organization is probably going to need to explore on their own. If you're really looking at going down the reimbursement and fee for service kind of a track, then you probably will want to look at what the coverage looks like, kind of in that realm of, prior authorization, verifying benefits. If you're in a value-based program where, maybe you have incentive payments for the quality metrics, or, you have some different revenue coming in for pay for performance, maybe you ultimately decide that you're not going to go down the route of billing at all. And in that case, then you get to decide ultimately like who is controlling it and how you want to move forward with that. But I would encourage, especially for, patients with those commercial and state partners, to really understand what the patient's insurance coverage is going to look like. Let's reduce those surprises of a patient getting a co-insurance bill or a copay bill, or it applying to their deductible, that type of a thing. All of those, when we're looking at patient engagement driven projects, all have the potential of decreasing that engagement for that type of a patient. So just something that you may want to think about as you're looking at another way to categorize your patients and who you're going to work with. Perhaps you just look at Medicare patients to begin with, and then you start to tackle those insurance specific questions later on down the line. So that's something you'll definitely want to look at. Go ahead, Patty.
Yeah, Kristen, I just want to let you know there's a handful of questions about billing that maybe we can address offline. We'll send it in an email follow-up to this.
Yes. So after this session, we will send supplemental information for the states and specific insurances that we've received, that we have some insight about what they're going to cover, as well as some billing resources about those CMS CPT codes. So keep an eye out for that, as well as the recording of the session and the slides, probably Thursday of this week. I'll get those out to you all. Fantastic questions, great collaboration, thrilled with the session today. And before we get into our call to action, I know we're right at the end, I would like to thank Dr. Humphrey again for your expertise and your willingness to share with the group. Very invaluable. Thank you.
Oh, you're more than welcome. And I would also encourage people that are starting SMBP programs to relate to the health plan by getting in touch with the medical directors or medical director. They're clinicians, and I can certainly help with the documentation as far as from the literature. But evidence-based medicine says this is the right thing to do, and often there's no communication there. So the medical directors have thousands of different things they have to pay attention to. I mean, they're I was wrapped up with, transplants and AIDS and everything else you can imagine under the sun. And I sometimes miss the science with things that are incredibly valuable. And so having them educated about SMBP, even if they can't get it through to get paid for now, they are going to be your ally to get it paid for down the road. And letting them know what you're doing is really important if you can. And generally speaking, medical directors are glad to talk to any provider. Sometimes takes a while to get them on the phone because they've got such layers of bureaucracy between them and the provider. But generally speaking, if you insist on doing that, that's very helpful.
That is a fantastic point, and definitely not a track that I was thinking of. So that is a really, really great, learned it, shared it for the end of the session. For your kind of state specific folks, definitely reach out to myself for Montana and the Hawaii region, and then, Patty for Montana, Deb and Brandy for Wyoming, and Aaron up in Alaska. And we do have some great contacts at their respective commercial and state payers. So if we can help you get in touch with some of those medical directors to get some clarity, we're happy to do that. So our call to action, building into session 3. So develop a process to identify and recruit patients. It feels like the vast majority of you kind of gone down a track of exploration, but look at what that process may look like. And then figure out, what are your technology strengths, what are technology limitations, and how much do you want that to play a role in how you're identifying your patient population. Second, train staff and SMBP billing codes and review the billing worksheet for your state. So as I said, we'll get those specifics out to you. And then set a goal for how many patients you plan to engage. Sounds like a lot of you are in that like 8 to 20 patient range, which is fantastic. I look forward to hearing how that goes in the next kind of round of implementation. You know, our 20 patients, are they taking up a lot of staff time? Maybe you need to pull that back a little bit as you start to explore the specifics around the visit types, patient education, patient training, that type of a thing. But I'm glad that we're all kind of in that same quantity of patients. So we'll get some good learning and sharing at the next session around patient engagement. So as I said, the slides and the recordings and any resources we have will be sent out on Thursday. So thank you everyone for your time today, and we will see you in 2 weeks on the 22nd of June at this same time. So thank you very much and have a great day, everyone. Take care.